Well, I'm Dr. Jim Del Rosso, a dermatologist in Las Vegas, Nevada, and editor-in-chief of the Journal of Clinical and Aesthetic Dermatology. And I am here to review the March 2026 issue of the JCAD, which has a variety of very interesting publications. And first of all, I do want to mention that we do have some new associate editors of the JCAD, Glynis Ablong, David Cotter, Diego Ruiz de Silva, Naeem Issa, Graham Lichman, and David Sider. And I'm very happy to have had the opportunity to bring them on to the JCAD. And they're all great additions. You could read more about them in my editorial message from myself and Dr. Phil Werschler. Also, the Residence Corner, I think it's very important. It's from Nabdir Abul Fatou. I hope I said his name right. He's a dermatologist, an MD, and it's about navigating the dermatology job hunt, key considerations when negotiating your first contract. And that's very important. Dude, everything feels good when you're going in and having that first discussion until you find out details later that you didn't think through. It's much better to discuss everything up front and get legal consultation in addition to your own gut when you're reading the contract. It's extremely important. And I think that's really a feature for residents. We also have letter to the editor, and this one is on expanding insurance coverage for wound supplies for patients with hidradenitis suppurativa. And there was no funding for this particular letter to the editor that came from Jordan Bui, right? And Jolena Bui and Dr. Negan Nabor. Hidradenitis suppurativa being the kind of disease state it is, where there's draining sinuses and people have to put on bandages and clean up areas with gauze and utilize a variety of different antiseptics, etc. It does talk about expanding insurance coverage. And I think for anyone that's involved with hidradenitis suppurativa, which many of us are, and our office staff in assisting the patients, that's a very, very important article. So let's go to the lead article. The lead article is by Chandler Johnson and others, with Tina Butani from San Francisco as the senior author. Uh, and this is on the impact of dupilumab on psychological well-being in moderate to severe atopic dermatitis patients. It was a phase 4 clinical trial. And admittedly, right up front, this was a small trial. It was it did not have a control, but it was an attempt to look at the psychosocial effects of managing patients with moderate to severe atopic dermatitis, utilizing the Psychological General Well-Being Index, the PGWB. And I think what's really interesting about it was about 50% of the patients. Now there were only 24 patients in the total assessment. About 50% of them were Asian. The mean age was 40, and it was about 60 to 40 split male to female, but keep in mind a small number. And really, what it showed in my mind, keep in mind that it's a small number and that there was not a control group. When you look at the psychological well being, and you follow that over time at 12 weeks and then at 52 weeks, even though the easy score reductions, I should say at week 16, not week 12, at 16 weeks and 52 weeks, that the easy score reduction was pretty impressive after 16 weeks. But the difference in the psychological well being index from baseline to week 16 was not different. Uh, from the start to that point in time in the patients that were being treated with dupilumab. When you go out to week 52 and you still see the even more significant improvement in the easy score, but the majority of it was achieved in the first 16 weeks, you see a much more significant improvement in the psychological well-being. So what this shows us is that what happens in the mind does not necessarily happen in the same stepwise fashion of what happens on the skin. And this is basically looking at it in terms of the area of eczema that's involved in some of the clinical features. So this is a first step, I think, in looking at this, but we always have to think about how these disease states affect the patients psychologically and keep in mind that that may happen at a different pace than what we're seeing as clinicians, wondering, why isn't this patient feeling better psychologically? Some might, some may take longer. So I think it's important to remind us of that, even though it's a small study. The next publication, Expanding the Topical Therapeutic Landscape for Atopic Dermatitis, a systematic review, and the lead author is Joshua Burstein. There's also Sarah Nahon, Diego Ruiz da Silva, and Graham Lichman. Graham Lichman, the senior author. This is an extremely well written article, and I'm not surprised when you see Joshua Burstein as the first author. He is an outstanding writer, and he is a resident at the University of Illinois, Chicago, a dermatology resident. I know him back when he was a fellow with Dr. Regal, and he has done a tremendous job on publications, and this is no different along with the other authors on this paper. It's extremely thorough on the 52 non-generic prescription topical therapeutic agents are currently approved by the Food and Drug Administration for atopic dermatitis, and an extensive review beyond that. The charts are very thorough, go through each of the therapies in terms of what the study showed, what the interventions were, what the outcomes suggested, and it is really a comprehensive, everything in all one place systemic review on topical therapy for atopic dermatitis. Extremely well done and extremely well written. The next article we have is a multi-center trial evaluating the safety and efficacy of a serum containing plant adaptogens in patients with mild to moderate persistent central facial erythema associated with rosacea. The lead author is Dr. Joey Drelos with her colleagues on this particular paper. And to point out, this is for persistent facial erythema of rosacea, which we have approved topical therapies that are designed to cause vasoconstriction, right? They're they're, they cause a vasoconstriction that leads to that persistent facial erythema, which is different than the papules and pustules of rosacea. But this is utilizing an over-the-counter serum product. We talked about plant adaptogens before. Plant adaptogens are in plants that are exposed all the time to insults in the environment, a major one being ultraviolet light, but also other things in the atmosphere. And they've now been harvested, of which there are many that are outlined in the article of what's contained in topical products with planted adaptogens, such as the serum, designed to try to protect the skin. And some of the things that these rich phytochemicals do are promote homeostasis, increase resistance to stress on the skin, mitigate inflammation, create improvements in the skin barrier, and also prevent premature aging. We do have some data that has previously been discussed with chronic photo damage. Now we're looking at persistent central facial erythema of rosacea. There is digital photography and some great pictures shown within the article to show you at baseline. And then over time, twice a day, application for 12 weeks, 51 patients, 38% of them did not use any other medications for rosacea. 13 did use some oral and topical medications for rosacea, but none of the patients could have more than 5 papules or pustules. So we were looking for that background. It was evaluating that background persistent facial erythema that increases during a flare but persists between flares. And the good news is the twice daily use of this serum did show a reduction in persistent facial erythema in and of itself. So it's important to consider that as an over-the-counter medication that can be used in these patients because that's a very difficult condition to manage. Next, we have a paper that comes from Aaron Chang, who is a medical student at University of Texas Health Sciences in San Antonio. There are several other authors, David Cotter from University of Nevada, Las Vegas School of Medicine, and also in private practice here at Las Vegas Dermatology in Las Vegas. We have the Cullen Eye Institute from Baylor College of Medicine in Houston, and some others from the University of Texas Health Sciences Center, from the Radiation Oncology Department, and also the Mays Cancer Center. So there are a lot of minds participating in this paper. The lead author, Aaron Chang, who is a very energetic and very talented medical student that has been involved with a lot of publications. I can't tip my hat to him enough. And really, this is a paper that stops us to think. It's not giving us a therapy that we're going to go out and use tomorrow. And it's looking at pumping up drug formulation. Proton pump inhibitors, which we give over the counter and by prescription for gastrointestinal disease, have been shown to reduce inflammation and fibrosis and may have adaptability to be used topically for scleroderma. And the article goes through this, looking at this as a potential adjuvant therapy in scleroderma and the support behind it at an early point in time. We certainly need more data, but just the fact that we're looking at some of these agents that we're not even thinking about in relation to the skin, we're thinking about what they do in inhibiting the proton pump in the GI tract. But the fact that within the skin, there may be mechanisms of action, and I expect that we're going to see further research in this area. Couple of other papers, and then we'll wrap up. Mohs surgeons' postoperative care practices for secondary intention healing, a national survey that was completed by the American College of Mohs Surgery. And it's really interesting to see how for secondary intention healing, which we often use in Mohs micrographic surgery and does extremely well in many of the patients, especially in sites that are properly selected, like concave areas that could be on the head and neck region or even on the lower legs. What is interesting is that the majority of the respondents utilized the way this has often been done, and there was variability between them, but the way it was been done over several years. Uh, Petrolatum emollients by almost 100%, topical antibiotics like mupirocin and gentamicin by a little over a third, and were actually associated with an increased infection rate, which is somewhat interesting. Antiseptic solutions like dilute acetic acid, and some others. They're all outlined. But what was interesting is despite supporting literature, the use of advanced dressings, antiseptics, and even topical timolol was relatively limited amongst this entire group, despite the fact that there's a lot of information on those. The topical timolol we've used in our practice for open wounds, especially for secondary intention healing. And we found it to be very, very helpful. And Dr. Rob Kirsner from the University of Miami has talked a lot about that and has published on that. It's just very interesting. And in terms of people typically go back to use what they've used for years and don't necessarily adopt as quickly as we might think some of the newer approaches. And then the final article is lichenoid drug eruption from cetirizine, which is an over-the-counter oral antihistamine treated with upadacitinib and dupilumab. And the subject of lichenoid drug eruptions has been something that we haven't quite had a complete handle on or a full handle on in terms of mechanism and treatment. We're hearing more about it because of biologic agents, tyrosine kinase inhibitors, and immune checkpoint inhibitors. But we also see lichenoid drug eruptions occasionally associated with some other agents, such as different antibiotics, antihypertensives, and nonsteroidal anti-inflammatory agents. What is interesting is this was written, the lead author is Dr. James Song from Seattle. And even though it's a single case report, I would recommend you dig further because you know when Dr. Song is an author, especially the lead author, and he does this with one of his associates there, a medical student is the second author. They did it together. But being the lead author, it's going to be well thought out with explanations of why, whatever mechanisms might be known, and the thought process. And treating this particular patient with upadacitinib and dupilumab, when the dupilumab alone, which has been shown to be helpful for lichen planus and even lichenoid drug eruptions, generalized lichen planus, which is interesting, didn't do the entire job, but it was helpful. Combining upadacitinib and dupilumab, which we have had reports being helpful as combination in some more difficult cases of atopic dermatitis, was helpful for this lichenoid drug eruption with excellent photographs. So if you're in this situation, even though we're talking about a single case report, there is very good rationale to include this as a consideration, keeping in mind all of the discussion of the risk versus benefits of the different agents being used and being properly selected for the individual patient. So I think this issue actually brought forward a lot of newer thoughts that maybe don't have this big plethora of large numbers of patients and double-blind, placebo-controlled phase 3 trials. But that doesn't mean that these other publications don't bring forward things that we need to think about that we face every day, and we have to look some for some justification on what we're doing now and what we're going to research further. So there's a wrap for March 2026, the same month as the American Academy of Dermatology meeting, which is to be held in Denver. So many of us are going to be busy with that, but we still always have time to bring you the pertinent, relevant information from the JCAD, and that is not going to stop. This is Jim Del Rosso, the editor in chief of this journal, signing off. And I want to thank all of my staff, associate editors, all the people in the background that make this possible from this journal. Thank you.